And now we've got the last item on our agenda, which is a presentation by Professor Maurice, Head of Department, Telehealth at UKZN. And his topic is Telemedicine Regulation, the Telemedicine Regulations, How Not to Do It. Please give him a round of applause.
I'm not going to be talking about the Internet of Things. I'm going to be talking about the harsh realities facing the poorest of the poor who stay in the outlying areas of in fact, South Africa and in many parts of in fact, Africa. Those people need telemedicine. We need to have an enabling regulatory environment for that to take place. So let me just see if I can work this. Which one? Have I got it upside down? Okay. Right, so just think about it. There in fact are concerns among doctors about whether they should be practicing telemedicine in South Africa, and it's deemed to be a contentious, in fact, issue. And their concerns, in fact, revolve around medico-legal aspects, quality of care. Is there going to be ongoing continuity of care? And, sorry, I seem to have jumped. I don't know what's going on. Okay. In fact, we have heard about security of data. We've heard about storage of in fact, data, etc. Now, at the moment, there are only 2 countries in the world that actually have telemedicine law. The first country here was 1997, and France has law. Certainly within the United States, each state has its own, or in fact has its own law. Now, if a colleague from, in fact, Malaysia phones me, and I give advice over the phone, and I'm not licensed to practice in Malaysia, the next time I go there, I could end up in fact, jail for the next 5 years. So one needs to have sensible law, and the man who drafted the law said to me in 2006 he had to draft it in a hurry, and then it was supposed to be reviewed 2 years later. And I met him in 2006, and there hadn't been any change yet. Now in South Africa, our Department of Health attempted to take that law and change, in fact, Malaysia and put South Africa in. Unfortunately, we managed to get that, in fact, blocked. In South Africa, we are fortunate. We have a national e-health strategy. And the National e-health strategy talks, among other things, about telemedicine and all the things that make you feel good. Increased access to specialist care, decreased patient transportation, etc., etc. It sounds the right thing to be doing, and it's there in the, in fact, strategy. We have an mHealth strategy, which also talks in a small way to, in fact, telemedicine. We have a draft national telemedicine strategy that was supposed to be launched 4 years ago, about now, four in fact, years ago. Still hasn't been launched. Now, the HPCSA. I hope there isn't anybody from the HPCSA in the audience, because I don't have much good to, in fact, say about them. In 2008, September, so that's now 8 years ago, they sent me the first draft of this document. Right? I, in fact, won't go into the fact that they got the definitions wrong, etc., etc. They still haven't, in fact, launched this. Now, I don't know how many of you can actually recall that in 2011, these were the, in fact, headlines in some of the papers. In fact, doctors under fire. Telemedicine is unethical, says the HPCSA. And I'll just skim through these. The, in fact, acting CEO said that it breached doctor-patient confidentiality. I have no idea how she reached that conclusion. She said that you have to have a, in fact, physical examination. The chairperson of the South African Medical Association, in fact, waded in and added to the problem. Again, all going on about face-to-face consultation. And then the HPCSA put their foot in it. They said there are guidelines for the practice of telemedicine within the state sector, but they aren't in the private sector. And you can't use the state sector guidelines in the private sector. Well, the guidelines for the state sector were drafted in 2008, in fact 1998, and were vendor guidelines they were very inappropriate. So in effect, we actually don't have any guidelines. Then, after all that, in fact, insurance companies waded in. And they have not retracted this statement. They say they won't assist you if you get into trouble practicing telemedicine in South Africa. I think it is just an in fact oversight that they haven't taken it back, but they haven't. So if we focus on the concerns of the HPCSA, they want a prior doctor-patient in fact relationship. But think about it, that isn't happening now. Small hospitals in the outlying areas, if they want their in fact x-rays, or if they need an expert opinion on an x-ray, they put the x-rays in an ambulance, it goes off somewhere else. A radiologist who has never seen the patient gives a in fact report. So there's no face-to-face. They want consent, and I'll come back to that. They want authentication, confidentiality, etc., etc., and I will touch briefly on these. A further problem in the HPCSA draft document is that there's no definition of must and should, and they use those two words in virtually every paragraph. Should can be the past tense of, in fact, shall. Right? So it needs clear definition. So in the absence of the HPCSA guidelines, I get phoned virtually every week and asked, is it safe to practice telemedicine? And I say to people, South Africa is a signatory or is a member of the World Medical Association. The World Medical Association has 6 guiding factors that ought to be followed. And I, in fact, won't go into them in detail, but that is the advice that I say to people. And these guiding principles also include the phone and the internet. And the six in fact, guiding principles are there. And if you look at them, it's confidentiality, continuity of care, standard of care, etc. And if you can abide by those 6 principles, you in fact should be safe in the absence of formal guidelines in fact South Africa. Now, the in fact HPCSA wants a in fact written consent kept in the patient's notes and a copy given to the patient. In its earlier version, it wanted the doctors at each end to in fact also keep a in fact copy. So now imagine somebody phones me. I suddenly have to get a hard copy of in fact the consent. Fortunately, we managed to get that taken out. But they still want a consent for every aspect of the telemedicine consultation. It has to be explained in detail. There has to be an explanation of the authentication of the doctor to whom the in fact information is in fact being sent. So, being in an academic institution, I sent a PhD student off, and she analyzed how consent was being used in an urban area among doctors and nurses, and we found that very few people took written consent for anything. The mere fact that you walked in to see me actually implies that I can do all sorts of things. So there was verbal consent and there was implied consent, very little formal written consent. We then said, okay, there are about 7,000 languages in the world, 2,500 languages in fact, sub-Saharan Africa, and in South Africa we have 11. Have the languages kept up with the advances in technology? So we took 40 words about IT that you would have to probably use in order to explain to a patient if indeed you were taking a true informed consent. We had these translated into Zulu by 5 first language speakers. They were back translated, and we did in fact all the correct things. And we found the first sentence of our informed consent. Only 1/3 of the people understood the meaning of the word consent. 7% understood the meaning of the word telemedicine. So how informed is informed consent? And they say that you should always take informed consent in the first language of the person that you are dealing with. So that's a joke actually, because now we are doing the same study, or in fact Nairobi, in fact Swahili, and we're getting similar findings. We then looked at confidentiality, and patients in the outpatients at some of the hospitals furthest from Durban were in fact asked a number of questions, and about a third of them share their phone, share their SIM card. So where is confidentiality if indeed one is sending messages out in this way? In fact, hospitals phone people to make contact with people who in fact don't have phones. So where is the confidentiality again? So all of these are things that we need to be thinking about within the context of the people who in fact need it the most. The in fact poorest of the poor who are furthest from centres. So a way of maintaining quality of care is to have guidelines. Now, who in fact develop guidelines? At the moment, it would be the blind leading the blind, because we don't really have enough experience. So basically in the developed world, guidelines are developed at about that point. Why? Because you've had enough people working for 8 or 10 years, they can share their experiences, they've got insight, they can come together, they can put it all together. Always have your guidelines developed by the specialty. Don't let the HPCSA or anybody else draw up general guidelines. So in fact, South Africa, at best, we are there. So how can we develop guidelines? Because guidelines will appease the HPCSA. Well, basically all I did, I went to the Telemedicine Association in the States, and they've got excellent guidelines. I stole their guidelines. I told them I had stolen them. I told them that for in fact psychiatry, I would develop guidelines for South Africa. I would hand them those back, and they could share them with in fact anybody who they wanted to. So that's exactly what we did. We developed guidelines for the practice of telepsychiatry in South Africa. We had them approved by the college, so they are formal guidelines. Now that we need to do for dermatology, etc., etc., etc. It says there, on the internet, nobody knows you are a dog. Okay? Authentication. How do you authenticate? If you go and see a GP, yes, outside his consulting area is his name. There's probably something hanging up on the wall with a big stamp on it. How do you authenticate them? You do it in good faith. You think that's the person who you ought to be seeing. So we have had some students working on how can we develop a device agnostic and service agnostic authentication. We in fact have worked it out in theory. We need to actually do it now. All right, spontaneous services. This is the thing that I find exciting now. And these are photos taken on people's phones and sent. The in fact image on. Sorry, let me ask you this differently. How do you black out the face of a person on a photo that you've taken on your phone? It's not easy. Right? So that's the first type of issue that we in fact face. The in fact next step that I'm working towards is a in fact 0800 number that the dermatologist on call will be dialed via a 0800, and the in fact cases will in fact be sent directly to them. Now, how did these spontaneous services begin? Back in 2001, I brought 18 or in fact 19 doctors from the outlying hospitals down to Durban. I gave them a camera, I trained them how to use it, I showed them how to get the image off the camera onto their computer and send an email. It worked for about 6 months to a year because there were too many steps in the workflow. There were no computers in the in fact hospital, so the doctor would have to make notes, take photos, go home, boot up their computer, old phone modem, send it off. A day or two later, the in fact answer would come back. Even with the best intention, in fact, nobody's going to keep on doing that, and it failed. So we set up dermatology by in fact video conferencing in 2003, and it's been going on ever since. I tried again in 2007 to actually set up store and forward. Failed again. Why? Because there still weren't computers available for the doctors. And if they were in inconvenient sites. So, in fact, dermatologist came to me probably 3 years ago now and said, hey, all those things that you tried and failed, it's there. The guys are doing it. And I said, how? They said, no, the junior doctors have worked out the guys who are being trained as specialists. If they couldn't make a diagnosis, they worked out that if they took a photo, sent it via instant messaging, they would get an instant message back, and they would learn something, and the patient would get a service that was far better. So it began with the junior doctors, and word spread. And doctors at the outlying hospitals then began sending in cases. So just think about it. I've taken a photo. The photo is on my phone. I've sent a text message. The text message and photo get to the dermatologist. The dermatologist sends back a message. The photo is on the dermatologist's phone. It's on my phone. The messages are both ways. We've got no evidence that anybody's taken informed consent. But there's a simple answer to that. In fact, a photo of the signed informed consent. That in fact solves that. But now, as was pointed out, in fact, dermatologists aren't securing their phones, and they're handing them over to their children, exactly as was mentioned earlier. So now all of these are issues that we need to be thinking about and in fact talking about. There's no paper trail. The dermatologist didn't know that you could email the in fact chat and the images. So that's in fact the next thing that we have to work out is how can we convert the in fact information from the email into a format that we can then put it into an EMR at some point further down the line. So I'll just show you a in fact simple case. That is the text. It's about 8 odd lines and some photos. And I'll blow it up, and you can see that there isn't all that much detail there in the information that the in fact dermatologist has been given. The advantage of how the images are managed within in fact WhatsApp is that all of the information is in fact there, and so each image can in fact then be expanded so that one can see detail. And as in fact you go in fact through that, you'll find that the dermatologist was actually at a conference in fact Seattle, and it was 2 o'clock in the morning, and because she got it, she sent an answer there and then. Right? So it becomes almost an instant service. So, are spontaneous services doomed because they are unplanned? We teach all sorts of things about how do you set up a successful telemedicine service, from having a problem, doing a needs assessment, doing an IT assessment, business plan, change management plan, etc., etc. Is it doomed because it's not planned, or is it an indication of the, in fact, maturity of the field? And I think it is. Should it be supported? Yes, we must support it. But how must we support it? We must find the weaknesses, address those weaknesses such that the HPCSA isn't going to be able to in fact stop people doing this. So we need to find a way of having evidence of consent, having evidence that there's a paper trail, etc., etc. And in just talking to people in the passageway at the med school, I'm finding that it's going on just about everywhere. I've been to meetings in fact Australia where I've talked about this, and I've had to say to them, hey guys, please just put your hand over your eyes because I'm going to ask you to answer something that is probably not in fact legal. How many of you have practiced telemedicine by in fact WhatsApp? 75 to in fact 80% of the people put their hand up, even though they aren't allowed to do it. In the States, they weren't that fast putting their hands up, but it worked out to be about 2/3. So we need to address the issue of consent, and I've mentioned a simple solution of just taking a photo of it. The security of data. The data are secure, and I will come to that. Confidentiality, authentication, and keeping a trail. Now, I think you will all have heard about the case in the States where the FBI wanted data from a phone and they couldn't get it. Now, WhatsApp didn't have very good end-to-end encryption until the 6th of, in fact, April this year. And previously it was only for an Android message, text only. It's been fixed. So seemingly now everything over all operating systems is secure. The data only stays on the server if it isn't able to be sent on. So if the person's phone isn't on and they don't have an internet link, it's not sent. And if it still isn't sent, after the 30th day, it is taken off the server. So, in effect, what happened? They've just had the Olympics. The CEO of Facebook, in fact Brazil, was sent to jail for between 48 and 72 hours. Why? Because he couldn't open a, in fact, WhatsApp message that was needed in a case in some in fact some court. They then looked to in fact ban it in fact India, and they in fact began by talking in fact England of it being banned. They then went to the Supreme Court in fact India, attempted to have it banned. That was in fact overturned about 6 weeks ago. So it seems as though it is secure in terms of the sending of the data. Well, the things that we have to do is to educate the doctors at each end about images, the in fact data on their phone, etc., taking messages off, sending emails on, sending all of the information on. Now the question is this going to be the solution or a simple solution for the developing world? I personally think it is. Is it going to work in the developed world? I'm skeptical, just based on the way that everything is so tied up, or in fact law. Now, we just have to work together to find ways to make it legal and ethically acceptable. And that is the end goal. The first time I put that up was at a conference in fact India, and I thought the audience was going to be upset, but it's the consultant working from home. He has his phone to his ear. He's working from his computer, and he's dealing with cases out in the bush, as it were. And that is the end point that we want to be at. Unfortunately, I'm still faced with the headache, as are all of you, of how do we get the HPCSA to think in a way that will enable ongoing telemedicine. Because if I can do that, I can then stay in fact calm. Thank you very much. I'm perfectly happy to in fact attempt to in fact answer any questions anybody might have. At the back.
I was just thinking, and using the Arab Spring as an example, regulation around media, they prevented people from, using newscasts properly. But social media overtook it. And I think that if you look at a media or a social network called Figure One, it is for medical practitioners. I'm not one, I'm an engineer, but I'm curious and I'm easily entertained by gross pictures from emergency rooms. So I am on Figure One as a policy maker. So anybody can join it, which is the risk, right? But I think if you read the comments on that social network, it's a doctor-to-doctor network. It mostly is a practitioner from the first world helping a developing country doctor that doesn't have the experience with certain symptoms, but they do use pseudonyms, so they don't use their real names. And I think that these social networks will spontaneously start taking over anyway, whilst we're still thinking about, making policy.
In fact, advice I give doctors who phone me is follow the World Medical Association, but make it clear that you are giving a second opinion, and the patient remains under the care of the doctor who has in fact referred. It sounds fine in theory, but if you're working in the state sector as a junior doctor and you phone a consultant, are you going to overturn the in fact things the consultant has said? most unlikely. And I have no idea what would happen.
Thank you very much.